So I'm Adam Rubin, and I'm a nail expert, and I have a nail clinic. I see almost exclusively nail patients. I have a pediatric nail clinic as well. And first, I want to recognize, Chris, you saw Chris Rubin had worked with me as a medical student. You can see he's really terrific and is doing great, so I'm very proud of him. And Campbell Stewart, who you're going to see next, did an enormous amount of work putting together the materials and really leading the PC nail study that we were working on at this meeting. And it seems pretty simple. Give a nail clipping, take some photos. Actually, it's an enormous amount of paperwork. You couldn't believe it. And he's all on top of that and is just terrific. So more from him after, and let's go forward. So basically here, I'm going to talk about, in order to understand PC nails, you have to know the normal nail unit anatomy, and there are definitely some unique anatomic features which are different from other areas of the skin, and we have to be able, amongst ourselves and other physicians, to communicate correctly about the different parts of the nail. So you can see here, I guess there's no arrow. Where's the, this thing, the laser? Uh-oh. There we go. Oh, there's the arrow. Good. Okay. So the first thing is this area, the skin, that is closest to your digit is called the proximal nail fold. And the white part over here is the lunula. And the lunula is the most distal part of the matrix. And you heard Chris say that the matrix is the part of the nail which is behind here, under the skin, you can't see it, that creates the hard nail plate. Then we have the nail folds, the lateral nail folds that are on the sides here, both sides of the nail plate that house the nail plate. This part over here is called the free edge of the nail plate, which we can do clippings from often for investigations. And the onychodermal band is a spot where in the normal nail, the nail plate is firmly attached to the underlying nail bed. And the cuticle is this little part that overhangs from the proximal nail fold and makes actually the sealant for the nail. If you look head on at a nail, this area right here is called the hyponychium, and again, the area where there are some histologic changes that are distinctive, and also where we worry about infections starting. So, here's the laser, it's the bottom thing. Okay. So, if you look at the nail in cross-section, and it is important for the other talks that are associated here, you have your bone here, the distal phalanx. The matrix, I told you, is under this proximal nail fold, and it produces the nail plate. The top part of the matrix, or the most dorsal part of the matrix, makes the top of the nail plate, the dorsal aspect of the nail plate. This is the proximal matrix, this is the distal matrix. So then the distal matrix actually makes the underside of the nail plate. That's why if you ever do procedures in this area, you won't get a permanent nail deformity. If people start messing around with the proximal matrix, your nail can be permanently altered. And I have some more slides in the future, but in PC, this is the main area that is affected, the nail bed. So if we go forward, also other areas of the nail, there are these different anatomic features, the ligaments which hold the structure of the nail and the distal phalanx in place. We usually worry most about the extensor tendon if we're doing surgery around the nail, but the collateral and interosseous ligaments are also important. There's a pretty good blood supply over there, and you can see there's actually an arcade over here. This is why you may have noticed if the nail gets traumatized, it bleeds pretty easily, and probably easiest in PC nails. There's also this so-called tongue and groove association of the nail plate and the nail bed. The nail plate in a normal nail sits very tightly attached to the underlying nail bed. It has an undulating form that really keeps the nail plate firmly intact. So we've already heard about the word Pachyonychia. It refers to a thickened nail. And I mentioned here that in PC, most of the change in the nails is related to thickening or hyperkeratosis in the nail bed. Here's that area over here, and you can see that over-curvature, which is this, quote, classic feature of PC nails, when all this hyperkeratotic material pushes the nail up and causes a bowing of the overlying nail plate. So, Mary said it, I'll agree. There is no one PC nail, and I will emphasize to everyone, unaffected nails are also PC nails, right? I mean, we know that the keratins are active in the nail bed, and if your nail looks normal, well, that's also a PC nail. I'm also going to show some pictures that there's variability in the expression within the same altered gene, and we have so many projects. One of them eventually we'd like to look at. We have plenty of photos that people have sent in, and try to correlate the appearance of the nails with the genetic mutation. So far, some people have looked at it, doesn't really seem to be a matching that can be done. So Mary gave me this photo a while back. Someone with a K16 mutation. You can see here the nail plate is actually this sort of thin part here, which is actually relatively unaffected. But you have a thickening here, and this is sort of a point of contention with Mary and I about, well, often these pictures when they're taken, the people are doing their normal grooming routine. So are these nails actually altered? Because when people have their photos taken, often it's not with a advice, don't do anything to your nails, let's see how your nails look like. It's usually like send in a picture of your nail, and usually there's normal grooming that goes along. So it's going to take some more work to sort of figure out what sort of component of manipulation is part of it. And so just a side comment. Here, another person, this is actually cut off, I can see it on my screen here, K16, so again, same gene mutation. If you look here at the so-called classic omega nail or PC nail, you can see that the nail plate itself, this very thin part, is actually relatively unaffected. It's bowed, and you can see the hyperkeratosis of the nail bed, which is actually pushing up the nail plate. Also the palmar keratoderma in the background. I don't know who this is, maybe it might be someone who may not be. But in any case, move on to K6A nails. I have an example here. This darker color in the nail may be just blood. Again, one of the things about the nail study, we don't really know a ton about the histology of PC nails, so more to come. But again, if you look at the nail plate itself, this part right here, it's actually relatively unaffected. It's all this hyperkeratosis that appears to be causing the physical change. And then here, another person with K6A mutation. It brings up the question, and we've talked about it, again, we need more data on it, but the issue of were the nails manipulated at all before the photo was taken. You can see there's a little bit of a pachyonychia, a swelling of the proximal nail fold, and a sort of hard to say, a hyperplasia of the or thickening of the nail bed. Not so much hyperkeratosis, but there appears to be a component of hyperkeratosis. All right, so I'll mention to you, I put some selected thing, I want to stay on time, but we had done this, Chris and I actually did a lot of work on this. So Chris, when he was a student, these things take a lot of time to eventually get out and so forth, and we're in the revision stages of the draft of this particular project. But we sent out the addendum questionnaire, which I'm sure many of you in the audience participated with, so thank you, about nail care practices and issues. Of 101 people responded with genetically confirmed PC. And the question is, why is it important to have more information about PC nails? Well, the first thing is, in order to improve the delivery of care for patients with PC, we need to know how are PC patients affected by nail changes, what have been successful ways of treating nail changes. So for example, one person will tell me something, a second person will say something, and like I said, no individual physician really has a lot of experience, so it's important to get this information, at least what has been working for PCers. And then how do nails in PC affect daily life? And this has been mentioned before about impaired function of the hands and feet. Certainly there's a component of the pain from palmoplantar keratoderma. And also, as physicians, we need to advise patients with PC. There are different nail care practices that I keep learning and so forth. Infections, we'll get to that in a minute. So the addendum questionnaire, and a portion of this questionnaire was dedicated to nails in particular, the psychosocial impact of nail changes, routine nail care practices, and things like methods of concealment of the nails. So to stay on topic, this is really brief, and just I thought a few things I would mention from the study that would be of interest to the audience. But we asked about a variety of tools or instruments that people use for nail care, and they're listed here. Some of them I'm sure are familiar. And one of the things that we found was that clippers and sanders were the most commonly used tools to care for the nails. And in every category, tools were used more frequently on the toes. So you can see toenails all the tools are used more frequently there. As a side note, you can see here, nails not affected. There's more fingernails not affected. And that it's interesting. I talked to some PCers here, and it's not commonly known that actually, well, at least among the people I spoke with, that the toenails are actually more commonly affected than the fingernails. If you look at the literature and you look at pictures that people show, often they show fingernails, so it's not, there's a lot of information that's not out there. And then other people had some writing responses, and I can share this with you, perhaps it would be helpful in your nail care, but things like the Dremel, which now I feel a little silly that we didn't have it on the original list because it's a pretty popular response. The pet egg. Actually, I can ask the audience here. It's a point of confusion for me, and I'd like to know. I thought that people, when they responded pet egg, that this was actually being used on the palmoplantar hyperkeratosis or keratoderma. Are people using the pet egg on the nails? So, first of all, let me just see if for showing hands. If you're using the pet egg, please raise your hand. So quite a number of people, more than 5 people, first of all. So answer the survey. Anyway, next thing is that of those people, how many are using the pet egg on the nails? One person.
Well, I have very little nail involvement, but I only have one pinky toe nail that's really kind of thick, and I just think it from that.
Okay, so this is important to know, and that's great. Thank you for answering, because then, yes.
Well, the pet egg, it has not just the metal part, it has a stick-on, like nail file.
Right.
So that's part of it.
But even so, it only seems that many people are using the pet egg, but only one person is using it for the nails.
I was using the metal part.
Metal part, perfect. So there are some other things listed here: horse nippers and dog grooming nippers and a belt sander. This other comment, which we'll have to get into more in the future, and again, I'll stay on time and yank me if I'm over. But anyway, this issue about nail avulsion and removal of the nail bed needs a lot more study because we don't know if surgical procedures are helpful, if people are happy with them. A lot of it is anecdotal. Nail infections. I'm not going to talk about them to save time, and Chris has already discussed this, but I'll mention from my angle as a nail expert that this is really an area of confusion for physicians and patients. And most physicians actually are not familiar with the correct terminology of the nail and complex nail disease. There is variability and no standardization on the approach to testing for a variety of nail disease. Most PCers have said 73% that they've had a nail infection, and the communication, even between dermatologists, is not good about what kind of infection we're talking about. I will mention this. I feel like I'm getting close to either overtime or getting close to it, but I'll say that the data that we collected shows, and this is a sort of a busy and complex slide, that nail infections become more of a problem or are no longer not applicable as PCers get older. Now, I'm seeing some heads nodding. This is actually contrary, and this is why it's good to have science and good to have studies and so forth, to, I think, popular belief in PC. What I have heard before is that in PC, it's usually children that are having nail infections more frequently. But it appears that our data shows is actually adults are. Now, again, we said the confusion about what type of nail infection, how is it being worked up, how is it being documented, all these things need more work. But this is interesting, and I think probably the best thing I can say. So, for example, if you're 21 and older, in this group that we studied, 101 people, 32% of nail infections were not applicable, but just in comparison, age group 1 to 5, 50% report that nail infections were not applicable. So they are applicable more as you get older. There may be some recall bias. There are things that we can talk about, but not in this. I'm already over. Nail infections, I've listed all these different kind of things. Chris already talked about it, and I'm happy to talk more about it or any nail issues. And then I say, in order for us to advise physicians how to care for patients with PC, we first need to understand what the exact problems are. And I have a mug on my desk, and it says, "I am still learning." And I'm here, I'm giving lectures, but I feel like I'm still learning all the time from individual people. So you need to tell me what we need to tell people, and part of it is the nail study, for example. Okay, briefly, it turns out that, so first of all, PC patients in general do not see physicians for their PC that often. We know that from the data, okay? It's one of the things I'd like to change. Of the physicians that are seen, a podiatrist is the most common contact that PCers will have with different providers. So first of all, I would say I'm friendly, I'm reasonably, meet me, I'm nice. So, I'm in Philadelphia, if you have a problem. People know that in my practice, PC patients get priority, they always get in quickly. But anyway, I think that it's important that we need to change this. And I have here that it's helpful to find a provider you work well with and who has an interest in learning more about PC. There's very few of us that actually know more than the general dermatologist. But I think if you find someone that is at least interested in working with you, I know it's very tiresome. You go from doctor to doctor, person's never heard of PC, they don't know it. The worst thing, it always gets me worked up when people just give antifungal medicines without testing you have a fungal infection. And sometimes doctors can be very pushy. Oh, this is what it is. You don't know. And actually, you know more than the doctor. And so I tell patients, you know more than me. Tell me what I need to know. I'll tell you what I know. We trade information, but try to find someone that will work with you. But I do think that in order for things to go forward, you do need to have contact with providers. I'm going to let Campbell talk about the clipping study because I'm probably over time. Anyway, so thank you very much. If there's questions, I'm happy to talk about them. Let me know around here or if there's questions. So anyway, other questions that I can answer about nails or PC nails? No questions? 2 questions. Dr. Hall, let's start.
What's the rate of growth of the nail and how does it compare with
Oh, this is great. Well, first let me answer, I don't know. If someone in the audience knows, I review actually some different manuscripts about rate of growth of nails, and
the question.
Oh, thank you. The question is, what's the rate of growth of PC nails? And for example, we know that yellow nail syndrome, the nails will grow slower, and psoriasis, the nails will grow faster, and in different seasons, nails will grow faster and slower. In pregnancy, nails will grow faster and slower. So in any case, it's something I will definitely look up and see what I can find in the data, but I don't know if it's actually, if the nail growth is slower or faster, and I could imagine reasons for both. But it's an interesting question. I'll look into it.
I don't think there's any data.
A backup for no data. Thank you. I know. As I say, I do review. People send me manuscripts all the time, and there's some interesting ones about nail growth, and people use nail files. So you use a file to sort of put an indentation in the nail, and you can see. One of the problems is that a PC is so rare, we don't have a cohort to study. So maybe we'll work on that, and it is important to know. Other questions? Yes.
Is there a difference in the Rubin cream versus spray when treating fungal infections?
I love it. So first of all, I might have a biased response, and I don't want to go over time, and people can ask me after. But in short, as a nail specialist, I'm very regimented about how I work up nail infections. So for the first thing is, in order to answer that, I would say that it has to be proven that it's a fungal infection. So a nail clipping is done. It's reasonable to do a culture. So in terms of the spray or the cream, If it's multiple nails that are affected, usually oral antifungals are needed. So if we're talking about a single nail, I also will do a chemical nail avulsion. So I break down the nail with urea, and then we'll use a topical. I don't personally have a comment about the spray or the cream. I think that if whatever the person is going to use, so if someone says, I'll use a spray, but I won't use the cream, well, if someone's using something, that's better than nothing. So I do that with patients. I don't think there's a study that says the cream is better than the spray. In my own personal opinion, I don't use sprays, my own practice. I use the cream, and people tend to be pretty happy. Let me just ask, I want to go over time. Is Mary here, or whoever's watching the clock? Okay. Jeff.
One more question.
Sure, yes.
As you present the information, I'm looking to see where I fit
Yes.
in your information.
Yes.
When you talk about what causes the infection, what might promote or
Yes.
create the infection,
Yes.
you mentioned wetness.
So I think that was Chris. So first, the thing I'll say is we're getting better at collecting data, and one of the problems, a major problem that we have, is this communication. And as a brief example, I'll say, so I'm a dermatologist and I'm a pathologist, and I have a weird whole thing for how nails and nail pathology. Probably isn't anyone else in the world that does this, but one of the things is, as a dermatologist, I'll get a call from a internal medicine doctor, general doctor, and they'll say, this person has a rash and I think it's really serious. You gotta look at this person. And then the person comes over and you're like, well, it doesn't look really serious to me. It looks like something common. But the only thing that's in common is that there's a rash there. And it's the same level of confusion from dermatologist to nail expert. Dermatologists say this person has melanoma, this person has this, and they have something totally different. They have psoriasis. So there's a communication issue with and that's why I said the correct terminology. That's why I even start with the anatomic areas of the nail. So I think the issue about what kind of nail infections are PC patients having needs to be defined. And I think once we can define what nail infection is happening, then we can start to work on what's the cause.
I was surprised not to see you mention trauma to the nail, because every nail infection I've ever had was caused by trauma.
Well, more study. I'd love to. It's definitely a future thing. And when we make up the question, you got to remember, we do ask PCers for input and so forth. But when we're coming up with the questions about what we want to ask, and we pilot them, and we ask Mary, and we ask other people for input, the issue is sometimes these things don't come up. Something that seems obvious to you is not obvious to me. And so it's the feedback, it's the interaction that we get to learn these things. So that's sort of the answer. I see Mary, I see we're back. I'm definitely over time. I'm getting in big trouble. I'm out of here. Talk to me after about nails. Anyway.